Welcome back to the Diet Doctor Podcast. I'm your host, Dr. Brett Scher. Today I'm joined by Dr. Sandra Palavecino. Now, Dr. Palavecino works in a small town in Seaford, Delaware, but she's originally from Venezuela. She got her medical degree at the University of Venezuela and completed her training, was practicing doctor in Venezuela, but then moved to the United States. So she had to redo her residency, which is just part of the rules for foreign graduates coming into the U.S., where she did her internal medicine residency again at the University of Connecticut. And as you'll hear, she then got interested in obesity medicine. So she's now board certified in both internal medicine and obesity medicine. And she's the director of the medical weight loss program at Tidal Health in Seaford, Delaware. And she has a great perspective on this because as an obesity medicine specialist and as the director of a medical weight loss clinic, she needs to know all the tools available for weight loss. So whether that's medications, whether that's very low calorie meal replacements, and of course, what diets are going to work best and how to work best with bariatric surgeons to get the most benefit out of what they're doing both pre and post-operatively. So she understands the whole picture. And I think that's so important, both from sort of a science perspective of knowing what works, but knowing also what works with the patient and the behavioral changes that need to happen. And that's where I really like her perspective. She talks a lot about behavior management, and those are certainly things that we do not learn in medical school, that we do not learn in residency. So to hear her talk about that as sort of the prime intervention that she does with her patients, I think is so important. And so I really hope you can take away some nuggets about what that means, what that might mean for you individually, what that might mean for physicians. And as you'll hear me conclude at the end of the interview, this is the physician people need to work with, right? If you really want to lose weight and you want to work with a weight loss specialist, this is the type of approach and philosophy I think so many physicians should have. And I hope it gives you hope that you can have that approach. Whether it's with her or with others who think like her, they're out there. And so if you're not getting this type of detailed approach and thoughtful approach, maybe it's time to start searching for someone who can give that to you. So with that, I hope you enjoy this interview with Dr. Sandra Palavecino. Dr. Sandra Palavecino, thank you so much for joining me on the Diet Doctor podcast today.
Oh, Brett, thank you for your invitation.
Yeah, it's my pleasure. So as I mentioned in the introduction, you are board certified both in internal medicine and in obesity medicine, and you're the director of the medical weight loss program. So you spend all day helping people lose weight and maintain that weight loss. So I want to talk to you about the specifics, but I'm curious about sort of how you got to this point in your career. Is it, in your training, were you always interested in focusing on weight loss, and sort of how did that happen? So give us a little background about how you got to this point.
Well, my medical career started a long time ago, right? And in my country, you go right after school, you go to medical school. So no, at the beginning, my interest was more in infectious disease, tropical medicine. I did work in the Amazon jungle with malaria. That was my most interest until I moved to Connecticut, where there's no tropical medicine going on. So, but during my training as a resident for the internal medicine program, they did have a small rotation through a weight loss clinic, which was very interesting. And when I moved and started working here in Delaware, I saw the big need of something else besides regular advice to my patients for weight loss. And that's what I got really, really interested. So I will say that was about 2012, 2013.
Mm-hmm. So I'm curious about the cultural differences just in terms of obesity and lifestyle. When you were in Venezuela, was it you weren't as focused on it because you were doing tropical medicine, or was obesity and metabolic disease simply not as prevalent, so it wasn't as obvious?
Definitely not as prevalent even back then. Remember, the country I live in, it doesn't exist anymore. So, but back then, even with all the wealth that we had, I don't think obesity was a focus at all for us as doctors. So that could also be parts of our education that is missing. We wasn't really never a focus over there. I did a very tough internal medicine program back home, very complicated patients, fourth level, hospital level. And it was very interested in all points of view, but obesity was definitely not on the top of anybody's mind at that point.
Yes, that must have been a little bit of culture shock then. You come to the United States, and all of a sudden, everywhere you turn, the majority of your patients are suffering from overweight or obesity, metabolic dysfunction. Did it take you a little time to sort of say, "Wait a second, this isn't right. Something's wrong here. What can I do differently?" Like, what was your progression like there?
Absolutely. So during training, you just focus and like finish your fellowship, even though this was my residence, sorry, even though this was my second time.
Mhm.
But you follow the rules and you do it again. And then I still thought I was going to go for infectious diseases afterwards. But then the opportunity came for us to move to Delaware. And there down here in southern Delaware, there's no teaching hospitals or places to further continue to your education. So I love internal medicine. Don't take me wrong. I said, let's do it. I'll do it in 100%. And I was in practice and I had my aha moment, right? Like a lot of us, because I was helping these patients I will be one of those doctors that will bring the obesity to the front for the conversation. But then that was it. I had nothing else to give them. Whatever I was telling them that we should be doing, this is what we should be eating. The next appointment, nothing's changing. The doctor's gaining a lot of weight. My labs were being abnormal. So I said, there has to be something else. So that's what I decided to investigate some more, found the Obesity Medical Association lectures about, how to get through the boards. And I know this is going to sound a little bit different, but I went to that conference and I met Dr. Andrea Enfield, and that was my aha moment. This is what I
Oh.
can do for my patients.
Oh, that's great. We'll have to make sure Andres hears this, that he was the motivating factor. That's
Well, no,
fantastic.
I told him the next time I met
Mhm.
with him, it's like, it was fantastic. You opened my eyes. I listened to, I was there for like 3-4 days, and his conference, maybe an hour, but that changed me for real. Came back to Southern Delaware and tried to give these teachings to the people down here with all our challenges. And it has worked great. It's been 6 years almost.
Wow. Well, so let's talk about some of those challenges. So, Southern Delaware, in a pretty rural environment, low
Uh-huh.
socioeconomic class,
Hmm.
I think so much of the low carb conversation kind of gravitates towards, grass fed, nose to tail, high quality. But that type of discussion just can't even start. It's a non starter for a low socioeconomic population like you have. So it's a big set of hurdles, I think, you have from an education and compliance standpoint. So,
Hmm.
what have you found as some of the biggest hurdles to people adopting low carb and
Hmm.
sticking with it? What do you see as some challenges?
Well, first, the challenges. Well, this is just to introduce you to kind of what I see all day when I'm driving to work. It's a very rural area. There are farms, but basically the farms are major economic factor here is the poultry and the poultry plants. So when you see farms around here growing corn or other grains, it's not really for human consumption, even though some of it gets to their population of the area, but it's basically to feed this poultry. um, and then that's kind of what I see here all the time. So even though it's a lower socioeconomic, it's very hardworking people that keep us fed in other parts of the country. So one of the challenges they always have when they come to visit with me is that I'm not going to lose weight because, I've never been able to do it because I live in Southern Delaware. And I say, well, think about this. You were not able to do it because we were not giving you the right advice. So I get that challenge a little bit out of the way. Then they go, well, but here we don't have like Whole Foods or, these brand supermarkets that will sell you all these fresh things. And I say, well, but here we're in a community that works with farms. So you don't have Whole Foods, but you have all these little farm stands all over the place that you can just go and get fresh food. So that challenge is a little bit, now you have to like them and know how to prepare them, but at least we get that a little bit out of the way. Other challenges like, yeah, but I don't have a chef. I don't live in California and I don't have a trainer. Um, and I say, well, we can definitely use this weather and these nice beaches around here. We can go for walks. And then you don't really, if you follow low carb, high fat diets, you definitely don't need a chef. Very simple recipes. We will make it happen for you. And then I think for me, the biggest, I am a very positive person. So I always try to make them understand those are challenges, but not obstacles. We will work with it. But I think my main challenge around here is the fact that many of my patients do have 2 or 3 jobs.
Yeah.
One of the major employees here are, like I'm saying, the food processing plants, which have shift work, and so is the hospitals and the medical system, which is the other big employer in the area. So shift work is a big thing, having 2 or 3 jobs, and not taking this treatment of obesity as very seriously. They think they go to the cardiologist for sure. They don't miss that appointment. Thinking about losing weight is not as serious for them until I make it forefront, and then that's how we go.
Yeah, so it's just so interesting that with your population, since they sort of are agriculturally based and have knowledge
Mm-hmm.
about food
Mm-hmm.
production and food
Mm-hmm.
system, that's an opportunity. That's something that they have that someone in the inner cities or in South Chicago or where Dr. Tony Hampton is, in those settings,
Mm-hmm.
they don't have that knowledge or that connection to food. So I think that's really interesting and a definite
Exactly.
benefit. Yeah.
Definitely, it's a point that they haven't realized until. Plus, it's not a big amount, but we have a lot of people around here that enjoy hunting and fishing, and that's definitely grass fed. So I said, go for it.
Yeah, yeah. You can't grain feed a wild animal. There's
Yeah, no
something to be
way.
said about that. But
Hmm.
that's great. I mean, I think that's such an important part of just society and knowledge in general, that more people need that connection to the land, that connection and understanding of where our food comes from. And I think that would change a lot of people's perception. So I really like to hear that that's the population you're dealing with and that
Hmm.
you take
Hmm.
advantage of that. You really can use
Right,
that to their benefit. Yeah, so
right.
great. But the concept of I don't need to lose weight is not important. It's not on the
Hmm.
forefront of my mind. So that's a definite hurdle you have to
Hmm.
overcome. And that is prevalent everywhere, especially when they say no one's really made it an issue before. My doctors haven't made it an issue, or I've tried and it didn't work, and I'm a failure, so I'm not going to try again. So this concept of other people not prioritizing it, or other people giving the wrong message. And
Hmm.
when you're trying to teach them something new, I mean, do you have to overcome that barrier of them being like, no, this is just one more thing that's not going to work. I'm not going to waste my time. Do you get sort of like the breaks right away when you start talking to people?
Yeah, so when I started to do 100%, because at some point I will did 50-50 internal medicine, and I opened my weight loss clinic and slowly build it up. But now I have all the time to spend with them, and I mean, I do have a schedule that I have to follow, but I will always open the conversation to how can I help you, and I'm sure most of us do that, because the more scary patient I have is the one who tells me my doctor sent me here, and I don't really know what I'm going to do here. So that's tough patient, because you need to convince them that this is an important part of their health and life, etc. Now, when they come to us and they already know, like patients is like, I want to lose weight, improve my diabetes, etc. You can immediately say, you're in the right place. We're going to help you. We're going to do our best to be there for you and help you. So that has been a big one. And like you said, I consider myself, I study a lot. I know the science. I go to our conferences. I follow the guidelines. I see the CMEs, and I know all that. But my big challenge was to explain that to the patient when they come in for the first time. What is obesity? This is not just some extra weight and around your belly. This is much more. And explain it to them and meet them where they are, so they can really take this seriously as I'm taking it. Listen to them, listen to the history of weight, how they explain to you how they've been gaining or losing, or what has happened to them regaining, and evaluate all the reasons that they think is related to the weight gain, for me
Mhm.
to just basically change their mind around it. Everybody blames the lack of exercise, and I'm like, well, I'm going to change your mind about this. Everybody lacks that having a chef or something. I'm going to change your mind about this. We can definitely do it. So that has a big challenge for me. Try to bring the science to my patient's level and make them understand how it's connected to real life.
So how do you relay the science in terms of the risks of obesity? Because we can think of obesity as a couple of different levels. There's sort of like the functional level where maybe you're winded going upstairs now, or you can't play
Hmm.
with your
Hmm.
kids or your grandkids like you want to,
Right.
and that's pretty pertinent for people and a big,
Powerful.
strong motivator. But then, you can read things about, well, obesity by itself isn't a risk factor for cardiovascular disease or death. It's only if you have the metabolic dysfunctions. And I don't know, if my take, there's a little bit of disagreement in the literature whether obesity is truly an independent risk factor.
Mm.
Do you go into that kind of detail? And I'd like to hear your take on that as well, because I'm not as up on the literature, I'm sure, as you are. But so what's your
No,
take on it, and how do
absolutely.
you relate that to the patients?
Listen, I have created different scenarios that I portray to my patients. It's like a theater in my room. Okay, this is when the food comes in here, and then this is what happens to the food when it comes in. So if you can storage much more, you will have obesity maybe without all this changes in your blood work. I try to use all analogies possible that have been working for me with the patients, like storage area and hallway.
Yeah.
How do you keep your sugars in a good level? Because you do have a big storage part, which is your fat cell. How your fat cells actually trying to help you not to develop diabetes until things get overwhelmed. And then the patients do understand that having chronic obesity or having diabetes, fatty liver, is probably the same disease. It's just we're seeing it from a different perspective. So that's when I introduce the eating plan, they don't feel like, oh, but I don't have diabetes and you're asking me not to eat sugar. Well, but we are on the same boat. This is all an insulin disease for I will say for the vast majority of the patients that cross my door. So I'm feeling very confident preaching to that big choir and then explain to them what they're supposed to be doing. Then you will always find those patients that no matter what you do, their obesity is very stubborn and it's really hard to lose weight. And then you try all the strategies.
Yeah. Yeah, that makes a lot of sense. And they come to you for weight loss. Do
Mhm.
they come to you specifically for low carb weight loss, or are you sort of a weight loss clinic using multiple modalities and low carb is one of those modalities? How does your practice style work?
Well, I like to say that I'm very open minded and I will meet the patient where they are and try to help them however I can. But I have to confess that most of my practice is low carb and intermittent fasting for the patients who want that, or I recommend and they follow. I did train both my dietitians that work with me in that area. I even work with a surgeon who our surgical patients are doing low carb pre and post op, and also, I mean, his patients, right? Pre and post op, and they are doing fasting. So I do believe, like, I tell my patients the reason why you're here today with me, the reason why you're having such a hard time losing weight or understanding this disease is the way you're going to eat, no matter which else happens. The food is most important, and that's the basis of the treatment. As a board certified obesity medicine, we can always prescribe medications, and I decided in my career that I wanted to learn about these bariatric surgery patients, how to help them understand pre-op and what to do with the patients post-op, because I thought, well, no matter what, they're going to have the surgery. They're not even coming to me for that. But somebody needs to understand how to help them and what to do with these patients for them to be very successful. Otherwise, they are going to regain the weight in some cases.
Right. And that's an important point. The recidivism rate or the weight regain can be high. It's not like you can undergo bariatric surgery and then go back to eating whatever you want. Like that's
Right.
kind of defeats the purpose a little bit.
Right.
So what they eat afterwards is important. So what kind of challenges do you face with post-op, post-bariatric surgery patients trying to get them to adopt a healthy low-carb lifestyle and stick with it?
Right. So I go back to the beginning. Like, okay, talk to me about before you had the surgery. How did you gain in the weight? Tell me the story. What were the things that you tried that did work, didn't work? Which medications were you on? Because that's gonna define what you're eating from now on. Um, for for me, maybe I'm a little bit biased because when they come to me, it's because they're in trouble. A
Mm.
lot of patients who had surgery with our surgeon here may not come back to me, but the ones who come to me are the ones who are in trouble. And it's a lot of explaining to them that how obesity actually works as a chronic condition, in the sense that when you lose all your fat, your brain most of the time or your hormones will work in a way that you will actually regain that weight. So you need to understand that our main battleground is not really weight loss. It's like you were saying at the very beginning, weight loss maintenance, or what I call a rehabilitation of our patients with this chronic condition. So like in any chronic disease model, you have prevention, treatment, and rehabilitation. So if somebody who has undergo bariatric surgery, what I see it is, okay, you were able to achieve a low weight, but now you need to keep it off by understanding how that it works inside you with your hormones, with your eating habits and your behavior, so we can keep it controlled.
All right, so I would imagine dealing with a surgical population is probably pretty different in some ways, although similar in a lot of ways, as dealing with a non-surgical population, because you're not just dealing with behavioral modifications, but you're also dealing with anatomical changes now that they've had surgery. So, people who want to eat one meal a day and make sure you're getting adequate protein, or even 2 meals a day with adequate protein and relatively larger meals. While that might work for a non-operative patient, will that also work for someone who has had surgery? So what kind of adjustments do you need to make with people when they're in the post-operative setting?
Right. So in the post-operative setting, at in the very first 6 months, they normally do work with the surgeon and the dietitians. So they follow their post-op protocol with this liquid diet, semi-liquid, like different textures, until they can eat just normal food. That's when they go back to me about 6 months after the procedure. And basically, we're still recommending for them low-carb diet, reminding them that carbohydrates and processed foods give them no nutrition. And now in their small space that they have available to digest their food, it has to be filled out with the most nutritional thing they can find in their plate in front of them. So I really emphasize that protein will be always first, then we move on to the vegetables, and there'll be no hunger or there'll be satiety by the time they even think about going to the carbohydrates. So it's something that we even teach them beforehand. So for us, it's been working really well to do the introduction with low carbohydrate. That's what the dietitians teach the patients too. And then post-op, we just continue with it. Now, when they're more advanced in the post-op stages, especially if they're having troubles with continued weight loss, or they're facing weight regain, definitely intermittent fasting has played a big role in our practice. I'm not saying this is what every surgical practice should be doing, but it's working for our patients. Intermittent fasting is so easy for them to understand and follow that it worked really well. So even my surgeon, it's embracing it, because we do it in a way that it's not about the time you don't eat, it's about eating when you're not hungry, and try to understand that, and that will be the principal symptom for you to go back to eat, even if it's after surgery.
Yeah, so hunger is such an interesting cue. I mean, it's a simple word. Everybody knows what the word means, but not everybody knows what it feels like. And not everybody knows what satiety feels like. And whether it's a, brain gut connection, or the fullness hormones or the hunger hormones, resistance to them. So that's something that kind of different people need to be trained in different ways. And I'd imagine that changes for a surgical patient or a non-surgical patient as well. So how do you help people become more in tune with sort of their hunger feelings and being able to react to them in different ways rather than, fear it or trying to avoid it?
Oh my gosh, I love this question, because this is really what I focus on every day, because I know how to get it done, but how to explain it. Hunger is the best way to explain how low carb will help you without showing them lab test results and like scale numbers. But patients are amazed. I say in my first ever appointment with them, always listen. Rule number one, we're going to decrease the sugar and starch processed food. Rule number two, we're going to eat only when we're hungry. And they look at me and say, well, that's every hour. And I say, it will be every hour but you will eat from this like options. And then you will be amazed when you come back. And they come back, like today I had a patient who did amazing. And then she's like, I don't even remember what I had. I'm like, well, that tells me you're not even interested anymore. So that's pretty good. So hunger is definitely a symptom that I follow very strict with my patients. And every visit we discuss, when are you feeling hungry? How are you feeling it? I ask them to describe it for me. Where do you feel it? And can you describe which color, which texture, which is it hot, is it cold? Because I want them to discover that most of the time we eat not because we're hungry. And even if we are, it's not a terrible sensation that you cannot delay for a few more minutes until you get to your actual meal and avoid all the snacking. Now, for surgical patients, for the like the changes that you're mentioning in the satiety and hunger hormones that they will get from this metabolic surgery, they will be not hungry, because otherwise, imagine, it will be torture if they're so hungry, can eat only so little. So the metabolic surgeries are achieving that, so they're not so hungry for a while. The hunger comes back, and at some point after like 9 months, 10 months, 11 months, when your body's leptin is so low and they're trying to regain this weight like crazy, so their hunger comes back, and this is perfect time to meet again with me and tell them, listen, we're going to just listen to the hunger hormones. We're going to eat this low carb approach because we want to eat the most nutritional thing you can have in front of you, and then they will continue their journey and trying to lose weight and be successful. So it's definitely, hunger is fascinating. It's just fascinating how we all perceive it in different ways and respond to it in different ways. And that's kind of core for my program. And one more thing I want to add in there is that, like I'm saying, I do use the science to explain the diets, and I tell them it's not that I'm telling you this is science and let me explain it to you. This is how we want you to eat. And I think I'm doing a great job, and the patient follows it. And some patients even take anti-obesity medications, and it's still a percentage of some, they have surgery, and it's still a percentage of my population don't lose weight. And that puzzles me so much. And this is when I have to go into this explaining what hunger is. It's like going to this counseling and behavioral changes, and that finally makes the trick, and they are successful.
Yeah, so those are really impressive and powerful behavioral health techniques that you're talking about. Where do you feel it? What color is it? To get people more in tune with it. Now, I can guarantee you didn't learn those in medical school or residency.
No, I didn't. Okay, I don't know if you remember, we were in the conference in Boca Raton, the low carb, and you know what I took? That was back in January, February before COVID, and one thing I took from that is that you were one of the speakers, and some of the others that normally treat the body. We're talking about the mind. You remember listening about the serotonin, fasting and all that, but the dopamine fast. So all the, and that's coming from a surgeon. So everybody who's treating normally the body is talking about the mind. And those doctors that were there for us, that were psychiatrists and psychologists, they were talking about how insulin changed how they treat their patients. So they're working with the body, right? But for me, that is like, I knew that. I just need to know how to get through these patients and how to explain to them that the behavior that follows this biological change is what you need to grasp to keep these and go through what I call your so you don't regain the weight, which is like your rehabilitation phase. When you become this person who, this is what we eat, this is how I keep my body healthy, and we are focusing in the things we could consume and eat and the times that we could eat, instead of focusing in the things we're left in behind. And that is
Yeah.
very powerful.
Yeah, I think that's such an important point because on the one hand, it can seem incredibly complicated because not only do you have to give a message of a nutritional program that doesn't contribute to hunger, but you also have to get the patient in touch with their hunger and learn how to respond to it. And none of these things are things you were taught. So for the average doctor to do that, it's incredibly challenging. And that's why it's so important to have experts like you who do this, who specialize in it, who know how to do it, so you can educate the patients. But also go to conferences where people are talking about it, trying to educate other doctors to then have that trickle down effect. And so we need sort of more and more of that. Now, do you find some of your colleagues are maybe confused about what you do or opposed to what you do or
You know,
argue with you, or how do you find that?
I listen, when I started, I just mentioned it before that I used to do this obesity medicine in my own practice as an internal medicine. And I have to say at the beginning, no, I was just not used about working with my patients. Nobody will refer anyone because I was doing it inside that same building, I imagine. They've known me for 2 or 3 years being a primary care in the area. When I moved to do it in another office, totally different and 100% weight loss, oh, I get a lot of referrals from my colleagues that are primary care too, because you can only imagine how long it takes me to go through all these teachings. Now, they are being my best supporters, and they send me patients because they want their patients to get better, but they don't have the time. And we always complain about that, right? So I make the time. We do talk, even though my appointments are saying 15 and 30 minutes, depending. But I do emphasize in these areas that we had no time when we were doing the primary care. So they're being very big supporters. And when they see their patients going back to them, they've lost 3, 5, 10% of their weight, and they're improving all their numbers in their blood test, they keep supporting for them to continue to visit with me, because our visits are very frequent. Now, at the beginning, when I started the low carb and all and high fat, because I really this is the program I follow, low carb, high fat, and the patients will go to my colleagues, the cardiologists across the street, and they will tell them, "No, I don't think you heard her right. I don't think she said that." And the patients will say, "Yes, she told us that in a class. We were all there." But now years has passed, and they are very good supporters. All my colleagues around, they say, "Just do what she said," to the point that for the first time, you see, obesity medicine was included in the top doctors of Delaware. It was always the surgeons who will be there, and your colleagues are the ones who vote, and they give me the award for this year. So that was that. I mean, that's for me a recognition of the whole obesity medicine group, which is totally a new thing, and they thought I was sitting here just prescribing diets, which is not really what I do. I will not prescribe a Monday to Friday diet. Somebody who doesn't understand why we're doing this, right? So that's a big
Right.
recognition for my colleagues.
Yeah, and that's showing that success speaks for itself. That when your patients are having success, doctors take notice, and that's
Take
what we
notice,
need more
right?
of.
Absolutely. And the government too. One other thing that we do here in Delaware, I don't know if you have these numbers, so let me just tell you quick. But Delaware is like number 16. This little state is the third smallest state, and we have we're number 16 in the state of obesity. Map with an incidence of maybe it's like right now, like prevalence rate of 34% obesity in adults.
Wow.
Those are patients with a BMI more than 30. So that prompted me to contact Medicaid. I mean, as part of the STAR program, which is the state representative advocacy representative, and say, listen, it's a little bit concerning that in Medicaid we need more help in here. So I mean, it was just an email, and I went to visit with the Medicare director and deputy director. They listened to me for 30 minutes. They say, Dr. Palavecino, we're going to do changes. And now Delaware, well, I have to say they were already open to obesity as a chronic disease. That wasn't new for them. But all the treatments, and said, listen, I'm sitting there every day helping patients to lose weight. You need to support. So with that meeting, they even changed some of the prescription panels. They now Medicaid has same number of visits as Medicare for obesity in Delaware, and that is fantastic. And it was just an email away. So those are things that we can do to help this population.
That's a great example of not just sort of sitting back and being passive about how you take care of your patients, but being active, not just with your patients, but with the whole system to really make an impact and make your job better at helping more people. I mean, that's fantastic. I love to see examples like that too.
That's another advantage to be in a small state, that you still have a voice, and you can go and get things kind of done.
Yeah, but I think so many people just see it as like, oh, there's this big bureaucracy and it's too much work. I'll never make any headway, so I just give up. So, okay, so maybe a smaller state's a little bit easier than a larger state, but still, the fact that you have a voice, use that voice, and you did, and that's a perfect example.
Delaware, until a year and a half ago, had obesity treatment as cosmetic treatment, and that has changed, and that was amazing for me. Yeah, I said, it's important. How could you have this as cosmetic treatment? This is 2019. Let me tell you about this.
That's great. Well, good for you. Now, we've talked about nutrition. We've talked about surgery. Now, there are also kind of a laundry list of medications that people can use for obesity. And, let's face it, a part of the American culture is sort of looking for the quick fix and wanting the quick prescription to just give me the pill I need to take to fix this. So do you use prescription medications for weight loss? What do you see as their role? Give us your take on that.
So I will say, I did did start prescribing some of these medications because I was curious to see how much could this help the patient. But even though I disagree with some of my colleagues, I will not prescribe in the first appointment because I tell them, listen, most of the research done in these medications were done after patients have changed their diets. If you look back at, let's say, I'm not going to name, but some of these drugs, they will do like at 8 or 12 weeks period of diet changes before they started using the medication. And I hang out from that to say, actually, this is, remember, most of the battle between diet, medicine, or surgery is in the weight maintenance phase, which is the hardest of them all. Okay. So there's no reason for me to start if you haven't done any changes in your diet. And I lose some patients maybe because of it, because they say diet doctor and they're like, okay, I'm going to get my medication. When they come to me and say, well, I don't know you. I don't know your blood work. I don't know if you could be pregnant. I don't know any of that. So we have to weigh and we'll apply. But this is great. This is all the things you can start doing even today, changes that you can do. And the patients stick with me. And if it gets to some point that we have the discussion about anti-obesity medications, I do use it. Recently, with a volunteer here in the clinic, he is a patient who lost a lot of weight and really wants to help all the time. We did a little bit of a research project in the clinic evaluating. It's like a weight loss register for patients who have been very successful, lost more than 30 pounds. Just we call them and ask them questions. Out of that big group, only 50% of them had ever or are taking medication. So it's something I do. It's not the biggest part of my practice because mostly is the diet plans. But yes, some of the drugs have been tried. Explaining to the patient, this is not going to change any behaviors. This is just to maybe show you how not being hungry means. So you strive for that with your diet, kind of like that way.
Yeah. It's sort of like the Band-Aid on the problem rather than fixing the problem itself.
Exactly. Even though some of the most newest drugs that you could use for other reasons, for example, diabetes, that have been proven to help with weight loss if the patient is diabetic or could benefit from it, it's a consideration. But definitely it will go with the changes on the behavior and the diet, which is my strong point.
Yeah, and I guess that's a good point. So the sort of new class of diabetes medications, the GLP-1 agonists that can really target hunger and reduce hunger to help people just decrease what they're eating. Sure, I mean that's a pretty strong benefit.
It basically increases satiety feeling. So they ended up eating less, but it's because they feel full faster. But it's been targeting their sugar metabolism for the diabetes, so we just might as well, instead of using others that could increase your weight, I will support that.
Yeah, right. But then the flip side is, well, instead of taking an expensive medication to reduce your hunger, why don't you just change the food you're eating to reduce your hunger?
Absolutely.
And they can have
No. I definitely go back to that. I definitely always agree with you. I always.
Hey, right. And I get that you do, but the patients sometimes don't get that. The patients sometimes don't understand from one step to the other. So it's that's why I can see the role of a medication almost as like a bridge sometimes to help people who aren't quite there, aren't quite ready to change their nutrition. But yeah, so I think the role of medications is interesting, but so is the role of the very low calorie diets, whether it's the meal replacement shakes or and I don't know, when I was sort of training, these were sort of seen as potentially dangerous and cardiac arrhythmias and electrolyte imbalances and low protein. It seems like they've gotten a lot better from that standpoint, that they're paying more attention. So do those play a role in your treatment as well?
We do have that option for when I see a patient who will fit it. For example, patients who don't cook any other meals and they're eating out all the time, I say, well, you might as well pay for something different. Now, I have to say that even though I kind of follow more a spare protein modified fast program than the very low calorie diet. So it's kind of a different approach because you don't take so many replacements. And I will tell my patients, listen, you at least one meal will be a meal because you need to learn how to eat. You cannot be in fake food forever, but it has a role, it has a place. And we have had independent research in diabetic patients when they took it. You remember those studies from like the United Kingdom for a year, even though they were getting the shakes for free. So that helped. And then half of the population got rid of diabetes, etc. So there are scientific independent research about spare protein modified fast as a program that they can follow, especially if they're diabetic. So I do offer it, but in my mind, at least one meal will stay a meal, because I want them to learn how to eat.
Right.
And mixing a shake may not give you the full concept of what is a protein, what is the fat, what is a high fiber carbohydrate, and what are the processed ones that we want to leave out.
Yeah. In my impression of the meal replacement and the very low calorie sort of medical supervised weight loss has always been, it works great in the short term, but the long term success is awful. Now, the evidence doesn't always support that, though. The evidence, there are some studies showing pretty good effects at a year, some at even 3 years,
Mhm.
but that's definitely not what I saw clinically. So I'm
Mhm.
curious what you see in terms of the long term success of that.
It's not something I support long term. I tell them, really, listen, it could be something we start with, get you excited, maybe get your sugar control. If somebody's already having like shortness of breath and very high sugars, it does definitely help, because they have more like a rapid event. But so we'll do a low carbohydrate diet with natural food. So if you look at a shake, which, don't tell me wrong, I do promote when it's the appropriate moment, and it has 10, 15 ingredients when eggs have one. And my patients have
Right.
chickens in their backyards. So,
Right.
that makes to me a whole lot of a difference. So I don't really try to keep patients long term on it, but I do use it when it's appropriate. Now, patients who go to the surgical route, they'll be in a lot of shakes. So I try to make sure that they understand that some of these ingredients now, since, for example, sucralose is not something we support so much, some of the products that we have here don't contain sucralose or aspartame anymore. So okay, let's try to at least use those. But economics is a big thing, and if the patient chooses
Right.
meal replacement, he will probably get it from our Walmart store. But yeah, I explain it's a way to do it. It's a way to start. It's a way to change things around when things are not working. But I do not support it long term. I haven't seen much results with it long term.
Yeah. And when it comes to weight loss, we don't just want weight loss. We want healthy weight loss, right? So what does that mean?
Absolutely.
That means, improving your metabolic health. It
Hmm.
means maintaining lean muscle mass.
Hmm.
And it seems like the research will support low carb diets, will support bariatric surgery, and will support these very low calorie meal replacements, that they all can really help metabolic health,
Hmm.
and can do it fairly quickly. So what do you see as some of the best ways to improve metabolic health for people that they can start, see the benefits, and stick with? And like, what do you use as motivating factors there?
That's the word I was going to tell you. It's all about motivation. That's why I told you the patient that scares me the most is the one who walks into my office and says, I don't know, my doctor sent me to you. And like, okay, that is very hard, because this is not going to work as smoothly. And those also have the motivation. So we work on that. I need to know your why, even if the why is I want to fit into this dress, or I don't want to die from all these other chronic conditions. Whichever it is, it has to be powerful enough for yourself. So whatever I'm trying to teach you, it will go and you will get it done. And we work a lot in the positive aspects. A low carbohydrate diet has a lot of things you can use and consume as food. They're very tasty, and focus on that instead of focusing on the things you are not eating. And remembering that losing weight does not depend on the food that you eat, because then I have my other groups that are so focused, and they said, okay, Dr. P, what about this keto diet? And I said, well, that's what you've been doing. I just haven't given it that name. And they start using all these keto supplements, for example. And I said,
Uh,
listen, you're not going to lose the weight with all these products that you're using. You're losing the weight for the things you're not eating. And so controlling your hunger with a more natural approach, that you can have, instead of buying all these products, you can have eggs for the morning, and tuna with vegetables for lunch, and then your dinner, and then try to eat that natural food, which contains 1, 2, 3 ingredients, and it's going to be so easy for you to do. Plus, I always tell them, don't feel alone, because anything I ask you to do, any homework that I give you, I'll be on it too. So I do
uh,
follow low carb. That's another thing about being in a small community. wherever you go, everybody knows you. Everybody knows you now. Even with the mask, people recognize you, and they look at your cart in the supermarket and they hurry away so I don't look at theirs in the store. Or when you're in a restaurant, people are paying attention. So I say, if I can do it in Seaford, Delaware, you guys can do it, and we're gonna teach you how, and we go on. But definitely, that motivation is the most important thing for them to make that loop and make this change.
Yeah, leading by example is so important, so important.
Well,
There's that old joke, never trust a skinny chef, as if like everybody who works with food is supposed to be
Well,
overweight, right? So, but
there's a lot of bias from doctors and from patients about weight, and I'd say you need to strive to be, healthier, leaner, but also healthier, and stop that. Change your tape up here of how you're gonna get there, and that's gonna be your more powerful advice. But I have to say, one day in the store, like I'm saying here, wherever you go, people recognize you. And I was looking at yogurts for my kids, and the lady says, "Listen, which one is the yogurt with the most fat?" And I look at her like, this is a weird question, but not many. Maybe this has a little because it's made with whole milk. And I said to her, "Do you ask me that question because you know who I am?" Or she said, "Yeah, I know you're the doctor who likes fat."
that's great.
That was funny. Yeah, that's a small
Yeah.
town for you. Okay.
Yeah, it's funny to be known as the fat doctor when what you do is you get rid of fat,
Yeah,
but you're known
but
as
it's
the
the
fat
first
doctor
one
for
in town that ever introduced the idea of eating fat. And when I used to do my group visits and give them a whole scientific background on why do we do this, their faces they go like, "My goodness, this is so new, this is so different," but they have embraced it. And like I'm saying, in that little report that we did for my patients, over 90% of them are doing low carb and intermittent fasting with more
right.
fat. So that is great.
So we've used the term intermittent fasting a number of times during this conversation, and intermittent fasting is hot right now, especially in the medical literature. We've just seen in the past month, we've seen 3
Tons,
studies
absolutely.
that have come
Mhm.
out just in the past month, and we've written about them at Diet Doctor, and they've got sort of different definitions of what fasting is and different outcomes that they're measuring, different protocols. So, what do you sort of fall back on as the main protocol that you like to use and that you see the most success with your patients with intermittent fasting?
I see it with the intermittent fasting protocols, not the alternative days or prolonged fasting, even though another half patients are showing up in my office are the ones who already fasting and already keto or low carb, and then they come with me for further advice. So those are already tough because they're already doing most of it great. But okay, let me go back to the intermittent fasting protocols. At the beginning, I tell them, "Listen, I know I ask a lot from you, but now I'm going to ask you to really actually wait and delay your meals." And we start with the 12 hours, 16 hours, and they just move on and they do great. You can hear and see for Della where you can talk to people about 16 A's and 23 ones windows to eat, and they do it and they follow it, and it's really great. I do have a few that do prolonged fasting on their own because they say I wasn't hungry for so many hours and so many days. Great. But mostly I support the intermittent fasting protocols, and I will say 90% of my patients get either introduced to the plan, and a big majority of them do follow it.
So that sort of the time restricted eating patterns of the
Absolutely.
16/8,
It's the
18/6s,
easiest
and
way to explain it, and to get them to adhere to the protocol. Even though I said at the beginning, you're going to be looking at your time and see what time is time to eat until you finally figure that you will eat only when you get hungry. So it will be at the beginning like paying attention and to the timing until you get trained in this sport, and then you will do it on your own, eating only when you're hungry. and
yeah.
and and when my patients get there, they're super happy. They tell me, "I don't even know how to explain your diet to people because I eat only when I'm hungry, and that's it."
Right. It's funny how that's such a foreign concept for so many people, but yet when you sinks in, it just sort of makes sense. And it's like, this is just the way it's supposed to be.
I have a few patients that I told them, "You need to trademark your comments," because he will say he was very, very super successful. And he's like, "Eating makes me hungry." Like, yeah, that's totally correct. Eating when you're fasting, your body fueling from the jet fuel you have. So it's amazing when they come with this on their own.
Yeah.
And I just support that.
Yeah. So one other question I've been wanting to ask you is when you see patients for the first time, do you see a number of them who say, I've quote, tried everything?
Mm-hmm.
Like they feel like they've exhausted
Mm-hmm.
all avenues for weight loss,
Mm-hmm.
and are sort of, I don't know, disappointed that they haven't been able to succeed, but they really haven't tried everything. Do you see that sort of defeatism a lot? Or I
Absolutely,
don't know if that's the right word.
but
Yeah.
I will say much more 2 or 3 years ago when nobody was really big on low carb and keto. These last 2 or 3 years, patients come to me and said, "I even tried keto, Dr. P, and it didn't work."
Ah,
So my job is to make them see what are the other circumstances that are going around them that may be beyond the food that we need to interpret. Like for example, can we be having a sleep? Well, first of all, let me tell you, most of the patients that come to me in the first appointment, they're doing 3 or 4 different diets in a day. They're doing meal replacements in the morning, low carb for lunch, low fat for dinner, and then they do portion control for. So it's like, okay, let's focus in the one and let's try it. And then the next time we also explore other areas. We do the history of weight, right? So changing jobs, working shift work, having sleep apnea. Which medications are you on? Maybe these patients, a lot of my patients
right.
on heavy mental health medications. Other things that don't feel like you cannot be successful. This is just we find your challenges and we work through them, and even if it's one at a time. And we do discuss all the like outside the box, beyond checking for your thyroid, which I think I found one hypothyroid patient in this whole practice, because my primary care docs around here are very good at figuring that one out. But is the other things that we need to address. And I love what the patient's like, I never thought that could be a problem. I never thought that could be a reason. Okay, let's figure that one out. And definitely whatever you're doing right now is not working. So let me give you a plan that we're going to follow. We do it for each one of them. And each
Yeah.
patient has the first appointment with me. And then the follow-up visits could be, well, they used to be groups with the dietitians and me. And now sometimes they follow with me or the dietitians, but we all in the same
Yeah.
tune there.
Such an important point that, we focus so much on nutrition, but there's so many other factors that
Mm-hmm.
can impact
Mm-hmm.
our success or our lack of success on our weight loss journey. So
Mm-hmm.
that was great. Now, you've mentioned shift work a couple times,
Mm-hmm.
and the easy answer is, oh, well, get off shift work, get on back on your regular, circadian rhythm, and all
Mm-hmm.
is fine.
Mm-hmm.
But people don't have that option. If
No, they
if you
don't.
have to work the graveyard shift, you have to work the graveyard shift.
Right.
So what kind of advice or little techniques can you use with those people to help them have more success despite their inflexibility of changing their schedule?
Right. So that is a big number of the patients, because those are the ones we already know is going to have the toughest to treat obesity and insulin resistance. So I'm not surprised. It's a big number of the patients that finally decide to go for a medical program or somebody with a doctor involved. So some of my tricks is to try to decrease hunger during the night hours by increasing their protein, and help them fast through those very tough hours of the night, and then focus more in the early morning or before work. And it has worked great with the patients. The other problem is the excess of food they have available during the shift work. For some of them, snacks and things like that happen a lot through
Yeah.
COVID. So now just changing also the behavior, already with the hunger decrease, by eating more low carb, high protein diet in between the shift, and then try to keep that behavior focus, willpower kind of moment during that night shift. For those who don't have food available, like some truck drivers or delivery person, I will just say, just change your circumstance. Don't have the food available, and then wait until your meal. So we apply same. It's just that I want my patients to feel that I'm focusing in their problem. I'm not giving them one regular diet for everyone and expect that everybody will be successful when they have to work through the night and sleep and semi-sleep through the day, or have a second job, and then we'll have to direct, okay, instead of stopping in this gas station, why don't we stop in this other one when they have this available, and so and so. So knowing your area, knowing the areas where they work and where they're getting their food is very important for me to give them a plan that they can actually follow.
Yeah, I think it's so important for a doctor to be aware of those circumstances. Because I can remember, working late nights in the hospital where you're working overnight shift. What food is available if you're hungry? Only junk. Oh,
Only
it's the
junk.
only thing available, and it seems to be everywhere in the hospital in the
Mm-hmm.
middle of the
Mm-hmm.
night. And I can just imagine if you're a truck driver driving through the night, what's open for you to stop and eat at? only junk. You don't have those healthy options. So to really sort of train them to think ahead and not get caught off guard and sort of preempt that, it's got to be so important.
Right.
But if you don't think about it, if the doctor doesn't think about it, you're probably not going to even bring it up. So it's so important that you're talking to your
I
patients
say,
about that.
tell me the places that you see in your road. What are the places, and then let's look at those menus. This is what you should be. If you're hungry, if you're not hungry, you don't eat anything. It's the simplest of the answers, and then you move on. But that has been very illuminating for them, because they finally, it's a plan that they can actually follow, and it's not from a magazine that you say, why I'm not losing weight if I'm following this magazine plan and it's not working for me. And then we talk about that a lot. Mm-hmm.
Well, you certainly lead as a fantastic example, both what you do personally, but how you approach your patients and the behavioral aspect, the communication, the way you communicate with your patients, the time you spend, and just sort of your understanding of them and your way to explain this. So I wish everybody who wants to lose weight could see you as their doctor. Obviously, that can't happen,
Yeah, please.
but they can certainly use you as the example of what their doctor should be doing and how they should be relating with them, and look for a doctor who does that. So, I mean, it's a wonderful example, and I hope people can take that away from this interview of hearing your approach and saying, gosh, that's what I want from my doctor, and that's what I should expect from my doctor.
Absolutely. So being the doctor in charge of the food, and we can manage their medications when we're prescribing, that make them feel so much comfortable, because they feel like it's a whole aspect that we're trying to cover for them.
Yeah, great. All right. Well, any last words you want to leave our listeners with, and then if is there somewhere they can find you to learn more about you?
Right. So I do have we didn't even talk about this, but I do have a strong will to try to help my Spanish speaking patients population, especially with COVID. That was a big eye opening for me. So I created YouTube videos that are free in Spanish. You can find me under Dr. Sandra Palavecino, in which we explain insulin resistance, the other hormones, how to do a low carbohydrate diet, and how to do intermittent fasting. It's just like an introduction. I'm also growing my Instagram account with both English and Spanish. So that will be also under Dr. Sandra Palavecino, Dr. period Sandra Palavecino, because in Spanish will be doctora, but in English is Dr. period Sandra Palavecino. And in here in Seaford, Delaware, well, I'm the one and only, so you can find me easily if you search weight loss programs in Southern Delaware, and you'll find me. So that would be easy. I have had patients that have come to me after researching dietdoctor.com or Megan's and Dr. Fung's website. So I even have patients coming from Washington, D.C., driving 2 hours to come here. But that's, we try to serve the area as better as we can.
Yeah, and I'm so glad you brought up the language barrier. We talked a little about the socioeconomics, but then on top of that, if you throw in a language barrier, it can get even more difficult. So the fact that you're doing those videos in Spanish is great. And at Diet Doctor, we have a whole Spanish section of our website.
I would love to. I would love to help. It's great. I think they need a lot of help.
Yeah, great. All right. Well, wonderful. Thank you for joining me. Thank you for all you do. It's been a pleasure. And I look forward to hearing more from you in the future.
Absolutely. Thank you for having me.